Aphasia. And that is exactly what we're covering today. By the end of this episode, you will be able to sit with any patient who has a language problem and ask them 3 questions and tell me precisely where in the brain the lesion is. I'm a neurologist and my goal is simple. I want to teach you neuroanatomy that you can actually use at the bedside. In this series, we're going to build a complete map of the nervous system and each pass go deeper and deeper than the last. You don't need anything else to follow this episode. Everything you need is right here. So let's get started. 2 broad categories first, expressive aphasia and receptive aphasia. In expressive aphasia, the patient knows what they want to say. The thought is there, but they can't get the words out. They're completely aware of the problem, and usually they're really frustrated by it. And that is exactly what I was doing at the start of that video. I knew what I wanted to say, but I was so frustrated because I couldn't get the words out. Now, in receptive aphasia, the patient produces lots of words, easily. Too many of them, but the words are wrong. The sentences are jumbled. They have no insight into any of it. They cannot understand language either. Yours or their own. So you're speaking a foreign language to them and they're speaking a foreign language to you. The one patient is silent and struggling and the other is talking, oblivious. Now, let me show you where those lesions are. As always, excuse my horrendous drawings. So we have our brain. And if you remember from the last episode, we have something called a central sulcus that separates the frontal lobe from the parietal lobe. So here we're going to have frontal. This is going to be parietal. This down here is going to be our temporal lobes. We have our 3 major lobes that I'm going to talk to you about today. Now, to start the ball rolling, we've got the central sulcus, like I mentioned, and at the front of the central sulcus, if you remember, is our primary motor cortex, and we would say that's the precentral gyrus, and behind the central sulcus is the primary sensory cortex, and we would call that the postcentral gyrus. Now, Broca's area is in the dominant inferior frontal lobe. So we'll write that right here and we'll say Broca's. It's the production center or expression center where the words are assembled and then they're sent out. And remember that the primary motor cortex lives really close to this. Now, Wernicke's area is in the dominant superior temporal lobe. So it's roughly around here. The comprehension center or the receptive center, where incoming language is decoded and understood. And so remember, the primary auditory cortex lives very closely to Wernicke. So that sound coming in, comprehending it, receiving it, and making sense of it is Wernicke's area. And connecting these two is the arcuate fasciculus. Now, fasciculus is just a fancy word for tracts. And so these are the nerve fiber tracts that connect the two. Now, the arcuate fasciculus runs through the dominant temporoparietal junction, linking Broca's and Wernicke's area together. That's it. That is your language circuit. Now, damage any part of it and you get an aphasia. Where exactly you damage it determines what type, and that is where the 3 questions come in. So I use this flowchart every time I see a patient with the 3 questions. All of these 3 questions are yes or no answers. So the first question is, are they fluent? So that's where we start off with. That can either be yes or that can be no. The next question we ask is, can they comprehend? That can either be a yes or a no. And the final question we ask them is, can they repeat? And again, that can be a yes or a no. First question, are they fluent? And that's not, is their speech normal? Just, are the words coming out without effort, even if they make no sense? So, is every word a struggle? Can they comprehend? So usually we start with simple 1-step commands. Close your eyes. Show me 2 fingers. If that works, move up to 2-step commands. Pick up a pen and put it on the table. Now, comprehension that holds for one step but then fails for two steps still tells you something is wrong. And finally, can they repeat? Start with simple single syllables. Ma, mama, papa. Then a word, pen, a short phrase. No ifs, ands, or buts. And that's the classic phrase. It's not meaningful, it doesn't have any content, so patients can't guess it. You just simply build up the complexity and see where things start to break down. Now let's go through each of these pathways to figure out what the patient might have. So we're going to start off with non-fluent. They can't get the words out. They're sitting at the bedside, trying to express themselves, and so they're not fluent here. Can they comprehend? Yes. Can they repeat? No. And this is your typical Broca's aphasia. They have an expressive aphasia, or sometimes called a non-fluent aphasia. So in Broca's aphasia, the production center is broken down. The patient can understand everything you're saying, but the words will not come out. And they know what they want to say, but the words can't come out. The speech is halting, telegraphic, effortful, short phrases, but a huge amount of effort just to get that word out. They're fully aware of what's happening, and that's devastating to them. They're frustrated and they're in tears. And like we spoke about, this is a lesion in Broca's area. And this is a lesion in the inferior aspect of the frontal lobe on the dominant side. Now, what if that same patient, non-fluent, comprehension is intact, but this time they can repeat? So if we would go down the same algorithm here, not fluent, yes, can comprehend, but they can repeat, that's something called a transcortical motor aphasia. So transcortical motor aphasia is a similar picture to Broca's. It's non-fluent, sparse, but ask them to repeat a phrase and they can do it. The lesion sits anterior or superior to Broca's area. So if I was to highlight this is where we would classically see a transcortical motor aphasia. Put this down as Broca's there. We usually see that in watershed strokes, and we'll go over vascular neuroanatomy soon, between the ACA and the MCA. So this area here gets damaged. Now, Broca's area itself is spared, so the repetition pathway is intact, but the connections feeding into Broca's area from the rest of the frontal lobe are damaged. So these connections. Now remember one of our rules of localization from the last episode. If the light bulb is not working, it's either an issue with the light bulb, the switch, or the wiring. Here, the wiring going to Broca's area is damaged. And so it resembles a Broca's aphasia, but the repetition is preserved. Now I love it. See how everything's slowly coming back together again from the last episode. Okay, next side. We've got fluent. Yes, the words are coming out nicely. Comprehension is impaired and they cannot repeat. What's that? That is our classic Wernicke's aphasia. Wernicke's aphasia, also called receptive aphasia, the comprehension center is down. Speech flows way too easily. Wrong words, jumbled sentences, sometimes completely made up word called neologisms. They lose the musicality of the speech. This is what Wernicke's aphasia actually sounds like. The figure was coming through the boras, and I told the Mipple that we should gondle before the stanter gets here. The patient has no insight. They're not frustrated. They're often confused by your reaction to them. They think they're making perfect sense. And where is the lesion in Wernicke's aphasia? Well, it's in Wernicke's area. Very simple. Wernicke's area is right next to that primary motor cortex, and it's that reception of sound and making sense of it and interpreting it. Okay, now similarly, what if we have the same picture? Fluent, comprehension impaired, but this time they can repeat. This is called a transcortical sensory aphasia. So in a transcortical sensory aphasia, it's like Wernicke in that speech is fluent, that the words are coming out, and comprehension is impaired, but repetition is preserved. And where does the lesion sit? Well, it sits posterior here, behind Wernicke's area, in essentially another watershed zone between the MCA and the PCA. So we'd say transcortical sensory aphasia in this region. So Wernicke's area itself is intact, so repetition pathways work, but the connections, once again, the connections that are going to Wernicke's area are damaged. And surrounding association cortexes are cut off, so comprehension breaks down. So spontaneous speech and transcortical sensory aphasias can have what we would call paraphasias and word substitutions, similar to Wernicke's, but generally less severe. The prosody, the musicality of speech, and the dense word salads that you hear in Wernicke's is much less prominent here. The most striking feature is echolalia. They repeat your questions back to you rather than answering them. So you might ask them, what is your name? And they say, what is your name? Right back. They don't comprehend. Remember, comprehension is gone, and they can't understand you, and all that's left is the echo. So they can process the sounds, but they've got no meaning. So when a transcortical sensory patient repeats, it sounds accurate and relatively normal, but they are only echoing you back clearly. That clean, accurate echo from someone you clearly cannot understand, that's when you think transcortical sensory aphasia. Okay, let's come back to our chart. This patient is fluent. Yep, they can comprehend, so we're going down this way, but they cannot repeat. So we're here. And this patient has a conduction aphasia. So in conduction aphasia, their speech is fluent and they understand you, but ask them to repeat and they fail. Now, interesting, the lesion is in the connection between Wernicke's as well as Broca's, and we would call that a lesion in the arcuate fasciculus, right here. We would call this conduction aphasia. So this is typically in the dominant temporoparietal junction. Do you see how that arcuate fasciculus is just kind of getting into the parietal lobe, but making its way to the frontal? Now, Wernicke's area is intact, so comprehension is normal. Broca's area is intact, so spontaneous speech is largely fluent. They just cannot reproduce the exact sounds in the right order. The spontaneous speech errors are much, much milder than Wernicke's, and importantly, they know they are making errors and keep correcting themselves, which in Wernicke's patients never do. So the result are what we call sound level errors. So instead of telephone, it becomes telemone. When you see a patient struggling, making errors, these sound level errors, so they might say telemone, telephone, so they're self-correcting, they're struggling and they're self-correcting. Wernicke's would never do that, right? And they're trying again and again to get the word right. That self-correction is what immediately distinguishes someone from having Wernicke's from a conduction aphasia. So if there's no monitoring and no correction, that's Wernicke's. If they're monitoring and trying to correct their errors, that's likely going to be a conduction aphasia. And that's going to be a lesion in the arcuate fasciculus. Okay, non-fluent, comprehension impaired, cannot repeat. So they're all the way down here at the bottom. This is a global aphasia. This is terrible, okay? This is nothing. Now you can understand why it's global, because it's so severe. You've knocked out Wernicke's, knocked out Broca's, everything's destroyed. This is usually a really large MCA infarct, and you've just knocked out the entire network. Patient cannot speak, they cannot understand, they cannot repeat anything. Everything is gone. And this is obvious immediately. And it's very devastating aphasia. I'm not going to color that in because then I'd essentially color in the entire language network. Now, these are the rarer ones. I really wouldn't worry about these too much, but we're just going to go over them nonetheless. So we have non-fluent, comprehension is impaired, but repetition is intact. And this is a super rare one. I'll bring this down here. And this is called a mixed transcortical aphasia. Now, they cannot speak, they cannot comprehend, but they can repeat, sometimes repeating everything you say back word for word, which is echolalia. Now, how can someone who cannot understand language still repeat it? Well, that's because repetition runs through a different arc, and that circuit is intact. What is destroyed is everything surrounding that. So the language circuit is an island. It can echo, but it can't think. Very rare, don't worry about it. And finally, we've got fluency, comprehension's intact, repetition's intact, And what do we have? It's called an anomic aphasia. The anomic aphasia means everything works except word finding. Name, nomia, anomic. The patient talks around the word, they can't access this. So show them a pen and they say the thing you write with. It can happen with small strokes, but it's also worth knowing in the context of neurodegeneration, it can be an early feature of Alzheimer's disease and is the presenting sign of primary progressive aphasia in frontotemporal dementias. If a patient is progressively losing word finding with no other deficits, then you need to think about neurodegenerative causes. Okay, so back to our map. The non-fluent aphasias, Broca's and transcortical motor. The only difference is repetition between the two, and that sits in the dominant frontal lobe. Fluent aphasias, like Wernicke's and transcortical sensory, live in the temporal lobe. Conduction aphasias are when the arcuate vesiculus gets damaged. Global, everything's knocked out. And those are really the four you need to know. Global, Broca's, Wernicke's, and conduction. The rest follow with the same logic if you can understand those four. So let's do a quick case. We've got a 60-year-old man, acute onset of difficulty with their language. They're having trouble getting the words out, very minimal verbal output, just a few words. When you ask them to point to the ceiling, they can do it. If you ask them to take your pen and put it on the table, they can do it as well. When you ask them to repeat words, sentences, and phrases, they can. Mama, papa, baby hippopotamus. What type of aphasia do they have? So if we go through our quick 3 questions, are they fluent or non-fluent? They are non-fluent. So this makes us think of the main 3 non-fluent aphasias. We think of Broca's, we think of transcortical motor, and we think of global. Are they able to comprehend? Yes, they can. So that rules out global aphasia. Those are really dense and they can't comprehend because they've also knocked out Wernicke's area. Now the final question, can they repeat? Yes, they can repeat. So this can't be Broca's because Broca's patients cannot repeat. So this is a transcortical motor aphasia. Where is the lesion now? Now it is in the dominant frontal lobe, which is where our primary expressive aphasias are, but it's superior to Broca's area, anterior to the primary motor cortex. Now, wow, that's some pretty cool localization just from 3 questions. Pretty amazing. Now you can understand why neurology is so beautiful and so elegant. Now, before we wrap up, some homework for you. I want you to comment in the section below. Can a patient with an aphasia write? If someone has a non-fluent aphasia, can they write down what they want to communicate, or is that destroyed too? And the same goes for someone who has a fluent aphasia. Now next week, visual fields and neglect. We have 2 cortical signs that are easy to miss if you are not specifically looking for them. We have one patient who cannot see half the world and another who does not know half the world exists. They're 2 completely different lesions, and that is next week. If you found this useful, subscribe, set a reminder. A new episode drops every single week. And if you know someone else learning neurology or neuroanatomy, send this their way. See you next week.